Good morning. We have no relevant disclosures. Enhanced recovery pathways improve outcomes by standardizing care across all segments of the patient experience. These protocols have been proven to reduce complications and hospital length of stay while optimizing financial outcomes in healthcare utilization. There's been widespread interest in implementation of enhanced recovery pathways, especially in colorectal surgery. But despite these advances, some patients continue to have unexpected, prolonged length of stay and fail enhanced recovery. So why is this important? The issue warrants attention because length of stay is an increasingly important measure of surgical quality and efficiency. Prolonged length of stay is associated with higher costs of care, increased resource consumption, and higher rates of postoperative complications and readmissions. Prior studies have been done looking at this, but no real change has come from them, as they've primarily concentrated on open surgery, used large administrative databases that lack patient-specific details, lack specifics on enhanced recovery protocol use and compliance, or report on outcome variables that cannot be changed. So our goal with this study was to identify the patient and procedural variables associated with failure of an established enhanced recovery pathway. Our working hypothesis was that the pre-op demographic and intraoperative factors associated with longer length of stay could be prospectively recognized and addressed to prepare for patients at risk of failing an enhanced recovery pathway. To this end, we performed a review of a prospective departmental database for elective colorectal resections performed using our standardized enhanced recovery pathway between August of 2013 and September of 2015. Patients were stratified into ERP success and failure based on a length of stay of 5 days, which was our mean of 3.5 days plus 1 standard deviation. Detailed preoperative demographic, perioperative procedural, and postoperative outcome variables were analyzed. For statistical analysis, we used univariate analysis to compare the patient demographic, comorbid, and treatment characteristics between groups, with student t-test and chi-square analysis as needed. Then, we developed a multivariate logistic regression predictive model to determine the probability of ERP failure. Our main outcome measures were the demographic and procedural variables associated with ERP failure. This is a snapshot of the pain management portion of our enhanced recovery pathway. This is why we call it multimodal, because there's opioid-sparing elements at each defined patient time point. And this was the last change made to our pathway before we started the study. During the study period, there was 83.6% ERP success and 16.7% ERP failure associated with prolonged length of stay. At first glance, the patients were similar in age, gender, BMI, and comorbidity per ASA score. But looking at the detailed patient demographics, there's stark differences in these patient profiles. The failures had higher percentages of every comorbidity, higher rates of prior abdominal surgery, and higher rates of preoperative chemoradiotherapy in rectal cancer patients. Preoperative anxiety, anti-anxiety medication, chronic pain and fibromyalgia, prior abdominal surgery, and chemoradiotherapy were statistically significant. Across groups, the indication for operation was similar. Colon cancer was the number 1 in both cohorts. And the procedures performed were also similar, with a segmental resection number 1 and a low anterior resection number 2 in both cohorts. Intraoperatively, we saw that the rates of complications and stoma creation were similar, but there were clear and significant differences in conversion rate, operative time, IV fluids administered, blood loss, and transfusion rates. And these differences resulted in higher complication rates, longer time to return of bowel function, longer lengths of stay, higher rates of reoperation, and higher costs of care across groups. Using the significant factors in the multivariate regression model and adding in values presumed to make a difference, like stoma creation, we found that preoperative anxiety, preoperative chronic pain and fibromyalgia, and intraoperative conversion were independently predictive of failing a multimodal enhanced recovery pathway. We know these factors either before surgery or before the patient even leaves the operating room, and this gives us time to make the appropriate changes. We recognize that there's limitations in the study, It was a retrospective review, so there's inherent limitations of the study design. It's also a single center, single surgeon experience, so it limits the generalizability. And there's no clear marker of compliance with our enhanced recovery pathway. But despite the limitations, there's clear conclusions. Certain patients are prone to failing a multimodal enhanced recovery pathway, and there are clear, identifiable preoperative and intraoperative factors associated with this failure. By addressing these factors during the preoperative intake or post-procedure period, preemptive planning can be done. Thank you.